Right, so just quickly, as you can see, 2/3 of the UK class is overweight or obese, which is 64%. This has huge effects on America and is getting more and more prevalent in children. So some of the comorbidities related to this, the main two here, as you can see, diabetes, CHD. Diabetes affecting 80% of people that are obese. So with this in mind, the obesity society we live in, there's more pressure on exercise professionals to prescribe the right exercise and the right nutrition for people. So what is an exercise professional? Is defined as a person who is trained to work in any field of physical and mental health. So some of these can include GPs, fitness instructors, things like teachers, and then people with the public, like public health campaigns and stuff. So the first exercise professional is the level 2 fitness instructor, generally working in a gym or leisure centre setting. Qualifications for this, a year college course, which is generally free, or a 4 to 12 fast tracked course by a recognised exam board, which is usually £400 to £900, and these are recognised by reps. So some of the problems with these qualifications that let's bring up is if somebody's done a 9-month college course, year college course, and they've been doing 3 days a week working with people, doing assignments, are they going to have more knowledge than someone who's been fast-tracked? All these people who've been fast-tracked could have the ability and confidence to deal with people, to know what they should be prescribing, and conversely who they shouldn't be dealing with, who they should be turning away or passing on to people that are more qualified. I'm just going to state the difference here between level 2, 3 and 4. So level 2 can work with people with no more than one CHD risk factor. Your level 3s can work with some referred patients as long as they're in stable conditions, they may have something like angina. Then your level 4s referred, so people that have had a heart attack and maybe looking to improve cardiovascular health. So the client base, general gym users, 16 onwards, all the way up to old people. This is where the comorbidities might come into play, the heart, lung, bone problems. Obviously, young people may have obesity and stuff, but the older people that generally are the ones with the more problems. So some considerations, take into account profit. Gyms obviously is an element of profit. They need the profit, they need to sell the merchandise. So there could be a bias towards the advertising, who they're aiming to get into the gym. They might be missing the messages to this older generation. And using things like the Christmas periods to use people's body image against them, and maybe make people feel bad about themselves to get people to go to the gym, which maybe have a negative impact. So just briefly, what is the GP? So they provide a complete spectrum of care within the local community, dealing with all problems from people, from babies all the way through to APs, like I say, a variety of comorbidities and problems, from mental, social, physical problems. The qualifications for this are very intense, 5-year degree in medicine and a 2-year foundation course in general training. They can do specialists, going to be a paediatrician or work with babies and things like that. And it's a science-based A-levels with minimum AAB. So some things to consider with the GP is how do they determine physical activity and how active someone is. Things like questionnaires and word of mouth, and are these reliable, or are they biased? Are people going to big themselves up, maybe lie, and not want to seem as sedentary as they are? And do they always prescribe exercise where it's necessary, or do they work for a pharmaceutical company where they might again be leaning towards profit and maybe they don't have the knowledge on the exercise and nutrition side, so they'd rather just prescribe the medicine as it's easier. And do they use any models to help people? Are they using motivational interviewing or something like that might push someone to exercise and help themselves rather than just be helped by medicine? So I'm just going to quickly, briefly, a referral system. I've got a leaflet here. So this one is one you can pay for yourself and look at the things the GP has to refer you, but it costs £2 a week. Things like osteoporosis, diabetes, and they look at improving those things for you and curing you. Like I say, £2 a week. More serious conditions, people that maybe need to lose the weight for surgery, such as gastric band, will get stuff like this for free. But it's just examples of something that to help at a small cost. So manage, prevent, and cure. So we're going to start back to the fitness instructor here. So I believe that all exercise professionals should do all 3, and they have a role in all 3 in some way. So fitness instructors prevent by encouraging people to go to the gym, offering advice to anybody that comes in and wants it, maybe deals for classes for people that don't want to join the gym and lift weights, maybe they don't want to do something like yoga or something a bit more fun, things like that. Manage by focusing on improving someone's current situation and diet, maybe using the exercise guidelines. However, like others, this can only be done if someone is referred or seeks help to the gym. And then cure through these referral programs while encouraging people to live a more active lifestyle. GP, prevent for anybody that comes to the doctor's office. Obviously, they might see that someone's gaining weight from the last time they've seen them, want to prevent a situation exacerbating. Manage by recommending public campaigns, exercise guidelines, and things like that. Referring somebody who might be able to help them more, and then cure through medicine, surgery. It's like someone didn't need a gastric band or something, that might be the last resort. So we're going to look at a few different exercise strategies now that promote health within the communities. So GP should be an advocate for health, should support and advise anybody that comes, and obviously there's a message in the doctor's office which advise people to eat 5 a day, exercise, get the jabs they might need and necessary things. Public health, locally endowed, we've got the website, they're in partnership with things like the Health Living Centre in Staveley, where they might offer classes for free for certain age groups, or certain people maybe that have not got as much money as others, and then promote through leaflets and things like that that may come through your door. Fitness instructors, so gym advertisement, maybe more high-end gym like Virgin, might have its own TV campaign, others might just advertise through social media, but again, does social media miss the older target audience as the highest percentage of users on social media, especially things like Twitter, is students. So again, that might be missed on the old generation, which maybe needed more than most. And then self-promotion through billboard signs and posting leaflets themselves. So dietitian, a bit more difficult for them. Anybody that sees them should motivate to change their eating habits and maybe set an example themselves. However, they can have articles in newspapers, journals and things like that that people can read and get the message across that way. And then teachers should encourage kids from a very young age to eat healthy and get active and encourage them to participate in sport in and out of school. Right, so some things to consider. That's the fitness instructor here. So there's the cost, how much gym memberships, how much travel to get to this gym is easily accessible for people, stuff like that. Are they offering clothes at a discount maybe for people based on incomes or anything like that to help them to encourage people? The type of the gym, like is it a more back alley gym? Is it people weightlifting in a really closed-in gym with heavy weights that may intimidate an obese person? Or is it a more friendly gym where they might feel comfortable? Are they going to recommend it off-peak hours? How are they controlling the temperature? As obviously, if somebody's obese, then the heat of the room might have a big effect on the breathing. So the self-esteem, understand I'll be using something like the teacher, there's some more information on that here, to help people see where they are, where they're at, where they need to be, the benefits of moving forward and trying not to relapse. Are they judging people on a mental aspect? Someone might have a very poor body image one way or the other. Have they got the knowledge and the skills to talk to someone about this and maybe recommend exercise where they don't need to be seen in mirrors, or are the off-peak hours where it's the least busy? So are they teaching people how to use equipment properly? Are they fully qualified to do inductions, and are they taking that seriously? Again, the temperature of the room, maybe they could use something like the Borg scale to link these in to measure people's heart rate and how fatigued they are, things like that. So like I say, are they qualified to do with all comorbidities, diabetes, CHD, osteoporosis? Are they generally have knowledge on someone's aging effect on the body, and how that might affect their willingness to exercise and their interest? So things to consider for the GP. The room first, is it too clinical? Might people almost feel interrogated, like they can't be themselves, and sort of they've got to allow that to talk about the questionnaires. The time limit, if you've got 10-15 minutes to talk about a problem, you might not feel you have enough time, you might feel it's important enough to talk to this person in this white coat with this stethoscope surrounded by this posh equipment. And the doctor themselves, if you've got a doctor that looks like this telling you you need to lose weight, are you not going to think, well, you're a doctor, you look like that, so why should I when you're not doing it? And again, I talked about the prescribing medicine. I've just got a leaflet here that shows you just how easy it is now and how accessible it is to get drugs rather than the exercise. Just limping into your pharmacy, not even having to see a GP anymore, just that easy option to get the medication rather than be prescribed the exercise. Right, so just going to look how all these link together. So like I say, we've got the GP that deal with everybody at the front line, and then they might pass people on to the physiotherapists for injuries, the dietitian, the nutrition side, the level 4s that deal with the people with the specific conditions, that then later on might get led on to level 3s and health trainers dealing with people that have more stable conditions, and then you've got the general public people, the level 2s, the teachers of public health, to pass on that information. Right, so now we're going to move on to the next part of the presentation, and I'm looking at the over 65s, just quickly some statistics here. As you can see, 55% of women, 75% of men over 65 are in the low activity level category. What do I mean by this? No exercise and less than 30 minutes a day of what they class as physical activity. And what does this mean? Age 65 to 74, men and women, 44% of women, 36% of men in the obese category. So what are the barriers? Why aren't older people exercising? Well, we've got a study here by Rational et al. 2006 that found the main barriers being poor health and fear. So by poor health, I mean they're in pain when they exercise, disease might prevent them, negative experience, maybe they fell in the past, they feel like if they exercise they put themselves at risk rather than helping themselves, uncomfortable feelings, stuff like DOMS, so that's putting them off. And obviously there's the lack of company, environment, bad weather might put an old person off wanting to leave the house at all, so that's something to consider. So let's look at the exercise recommendations. First, NHS, 150 minutes, moderate intensity exercise. They don't define what they mean by the vigorous, the moderate intensity, so maybe that's something they could work on so people understand exactly what they mean by that. The World Health Organization, exactly the same. So I found a study that test these guidelines for over 65s. Over 2,500 subjects. It's got the full study here for further reading. Over 2,500 subjects, 46% of these fulfilled the criteria, with 16% moving on to the more enhancing exercise. The 16% that did move on was the most educated out of the group, with education, at least higher education, at least A levels, at least the BTEC. So that's something to consider. The biggest dropouts were women 80 years of age plus. So again, the older they get, the less people seem to be interested in exercise. So the outcome of the study was to promote exercise and educate people on it. So some pros and cons of this. Some cons first. It doesn't state physical activity, it's only exercise, and it is self-assessed. So people might have been active all day doing housework, doing gardening, and then not took this serious, whereas someone else might have done nothing all day, and this might have been something they look forward to, might put in full effort. So they might have moved on because they was enjoying this more for reasons like that. The some pros, obviously, it shows that it's not only possible for older people to benefit from exercise, but also to advance and progress, no matter what age you're at. There's always that possibility. So it's very beneficial. So how does these guidelines compare for an average adult? Again, 30 minutes a day, moderate intense exercise. It's the same again. So by this, what they're saying about this is that someone that's maybe 22, 25, who's been sedentary, is expected to jump into the same level of exercise as someone who's 64 and maybe sedentary, whereas maybe there needs to be more guidelines, more specific comorbidities, because the 64-year-old might have more joint problems, they've been sedentary. I mean, they both might have weight problems, but that might affect the older person more because of the lack of recovery rate as you get older. So the comorbidity guidelines, as you can see again, hypertension, diabetes, all the same. So there's some considerations I think that need to be taken into place when dealing with exercise prescription and guidelines. So, medical considerations. Is medicine making maybe someone feel nauseous, maybe they can't exercise as long, maybe something that affects them. The general aging effects, feeling tired, stuff like that, maybe they need to start off small, start off an hour a week and build that up for people. Maybe they've had surgery, maybe they're in pain when they exercise, maybe something that needs to be built up over time, and then obviously there's stuff like obesity, hypertension, all needs to be taken into consideration. So specifically now I'm going to look at care homes, which I found the biggest problem in the over 65s. 70% of men it's when it classes inactive completely. And what does this cause? 400 million hospital beds each year for people over 65, with an annual 70,000 hip fractures. 1 in 10 people, as talked about the barriers earlier, who fall are afraid to leave the home, so they won't get exercise in if they're afraid to leave the homes. So an intervention I found, So since they've started this campaign, 700 care homes across London, they've had a 28% reduction in falls, improvement in mobility, staff can join in, it's fun. It's also backed up by Age UK. We'll find some stuff highlighted there, promoting how exercise prevents falls, prevents the risks of old people. So other reasons this is good: cutting the cost of the NHS, reducing the stigma attached with old people and exercise, educating them, the company, so obviously it's very beneficial. So some other initiatives that there are available to assist people. So just before I move on to that, I just want to state one thing that I think is missing from these interventions is the nutrition side. And there's something that I've highlighted here about how malnutrition affects the over 65s and how hydration can have a big effect on the mobility and the willingness to exercise. So onto these now. The Change for Life was there for the nutrition benefits. National Child Development Programme, educating from a young age. We talked about the educated people moved on. So if this is done from a young age, obviously it's going to have more effect as they get older. The say in the mental health aspect is all here for further reading. Reducing the stigma attached to it, people with mental health, willingness and how exercise can help, and willing to talk to other people about it. So just some of what we've talked about today. So more needs to be done for specific groups. Individual catering, I don't think guidelines can be so general. I think they need to take into consideration age, any comorbidities, and they need to take into consideration how long a person has not exercised for before they jump into exercise. If someone's not exercised for 20 years, obviously it needs to start off smaller. More like education side, as we've mentioned with the National Child Programme, can start early, but it's also never too late to educate older people on the benefits of exercise and how important it is. GPs and the patient should have more intimate relationships so people can talk to GPs about anything and feel comfortable discussing the physical activity and nutrition side, not just on what medication might make them feel better. Fitness instructors need the suitable qualifications, only to deal with the right people to make sure they're confident and they've got the knowledge, and if not, then they need to seek that knowledge before they deal with the public. Thanks for listening.
Thank you very much, Jamie.